consider adopting a resolution that supports the county organized health system. Is this be carried by you, Mr. Kehoe?
Thank you, Mr. Modi. Good morning, ladies and gentlemen. We have a very important resolution and topic to discuss this morning, and I'd like to read this resolution and then hear the presentation, and then thereafter provide the board members with an opportunity for questions, and then we'll vote on it if that meets with the pleasure of the chair.
That's fine, Mr. Kehoe.
Thank you. So this is a resolution of the Board of Supervisors of the County of Shasta affirming its support for a county organized health system model of Medi-Cal managed care for Shasta County. Whereas the number of Shasta County residents enrolled in Medi-Cal exceeds 42,000, or nearly 1 in 4 of the population of the county, and the Medi-Cal program supports the health care needs of low-income, aged, blind, and disabled residents. The current Medi-Cal system in Shasta County of unmanaged fee-for-service health care delivery increases the overall costs of the Medi-Cal program and is not as efficient with taxpayer dollars as managed care Medi-Cal, where health care is coordinated between providers and primary care and preventative services are emphasized. The state of California is expanding Medi-Cal managed care into the 28 rural counties that are now fee-for-service only. And the Department of Healthcare Services, DHCS, has indicated that the expansion of Medi-Cal managed care will likely be accomplished through a competitive bidding process with limited local input or oversight. Whereas the Shasta Health Assessment and Redesign Collaborative, with representatives from hospitals, clinics, private physicians, the local medical association, and county government, has been working since 2009 to improve the healthcare delivery system in Shasta County and surrounding regions, and is advocating for a well-designed expansion of managed care to rural counties that addresses our geographic uniqueness and particular population needs. The county organized health system model of managed care has been shown to be a most effective Medi-Cal managed care model for improving patient health care outcomes for Medi-Cal recipients, with a focus on prevention and primary care, and allows for local representation in its governance structure. Partnership Health Plan of California is a managed care organization with significant experience with the Medi-Cal populations in Solano, Napa, Yola, Sonoma, Marin, and Mendocino counties, and has committed to work with Shasta County and other Northern California counties in providing managed care services to our Medi-Cal beneficiaries through the COHS model. Shasta County Medi-Cal recipients would benefit from the expansion of PHC in the county, improving their access to care and expected health care outcomes, should the state of California and PHC agree upon the terms of such an expansion. Whereas the Shasta County Board of Supervisors agrees that improved patient health outcomes at less cost to the taxpayer should be the main purpose of adopting a managed care model for Medi-Cal in Shasta County, and anticipates the state of California will adhere to the recommendations of the elected representatives of Shasta County when deciding how to organize Medi-Cal managed care within Shasta County. Now therefore be it resolved that the Board of Supervisors hereby affirms its support for the COHS model of Medi-Cal managed care for Shasta County in general, and the expansion of PHC in Shasta County specifically, and directs county staff to work with PHC and the local healthcare stakeholders to ensure the most effective transition possible to a Medi-Cal managed care model. And then following the presentation, ladies and gentlemen, we'll ask the chair to call for the vote. Good morning, ladies.
Morning.
Good morning, Chairman Modi and honorable board members. My name is Doreen Bradshaw, and I'm the Executive Director of the Health Alliance of Northern California. But today I also come before you as the co-chair of the Shasta Health Assessment and Redesign Collaborative. And we are a group of healthcare providers that have been meeting for a few years to discuss ways to address health reform and what it means for Shasta County. But I would also remind you, this group was born out of the Mental Health Assessment and Redesign Collaborative that started in 2006. So we've had basically very strong relationships with our healthcare providers for a number of years beyond this. But since 2009, we've been really looking at healthcare reform. Since 2009, we've been working on ways to reduce and strategies to reduce inappropriate use of the emergency room, looking at ways to coordinate referrals with amongst all the agencies through a patient navigators network. A lot of referrals happen. We don't know if the patient ever receives the service, so we're looking at ways to get all our referral coordinators to work very closely together. And then also we're working on developing a plan for health information exchange. A number of our healthcare providers have electronic medical records, and that's the tool, but our success will be when we start exchanging the information and really use that to monitor patient care. Let's see. We have a number of partner organizations that are involved in that, as was stated in the resolution. It's clinics, it's hospitals, it's the North Valley Medical Society, and also members of the county agencies for public health, mental health, and social services, and private providers. Actually, excuse me for one moment. Yeah. If you could have just one moment.
You know, perhaps while she's working on that, maybe, I see you have a number of people who are with you today. And,
that would be great.
And maybe they could just tell us who they are and who they're associated with. It'd be kind of nice to know
If
that.
members of the collaborative could stand up and identify yourself. Thank you so much.
I'm Harold Carlson with Shasta Community Health Center.
Robert, the Shasta Community Health Center.
Good morning, I'm Kathy Sevilla with the Health Alliance of Northern California. Lynn Doran, Hill Country Health and Wellness Center.
Carla Alexander, Health Alliance of Northern California.
And I'm Deb Schoenfelder with North Valley Medical Association and with a local representation for the California Medical Association.
Great.
Academy Health and Human Services Agency.
Thank you. I appreciate that. To get a chance just to hear your names and put the names to the faces.
My apologies. Sorry.
All right.
So today, the purpose of our presentation is to request the adoption of a resolution supporting a county-organized health system model of Medi-Cal managed care for Shasta County. If you look at Shasta County's current Medi-Cal program, about 1 in 4 residents are enrolled, of our population is enrolled, and this program supports health care needs to low-income, aged, blind, and disabled residents. The current system is an unmanaged fee-for-service delivery, which basically increases overall costs, and it's not as efficient using with taxpayer dollars as managed care. The patient has to navigate themselves through the system by finding a primary care doc or a specialist, whatever, that will see them. The managed care services will coordinate between providers and focus on primary care and preventative services and reduce inappropriate use of the emergency room. As we say, the beginning in June 2013, the state will expand Medi-Cal managed care into 28 rural counties, and those are the gold counties on your map up there. The state has been operating Medi-Cal managed care since the mid-1990s, and you will see that there's different models of managed care. There's 2 counties, Sacramento and San Diego, that are geographic managed care, and that is where commercial health plans and as many as want to operate in those provide care to those Medi-Cal populations. There's 14 counties, which is the light purple, that have a 2-plan model. One is a local initiative that can be run by the county, and then also the other plan would be a commercial product such as a Blue Cross, et cetera. And then the rest are 27 fee-for-service counties, and I want to say there's numbers between 27 and 28. A proposed county organized health system is for Lake County, which is next to Mendocino. And then we're going to speak in a moment about the county organized health system. The Department of Healthcare Services is in the process of developing a competitive bidding process for a geographic managed care, which we don't believe is the preferred model for operating, providing services to the Medi-Cal population in rural communities. Over the past few years, the SHARC, Shasta Health Assessment Redesign Collaborative, has been working on strategies to improve rural healthcare systems in our communities, especially for our uninsured and underinsured. We have been advocating for well-designed expansion of managed care to rural counties. This just was announced in January as part of the governor's budget, and it's moving fast. So we are really trying to have a voice. We've been convening educational sessions because our folks haven't operated in a managed care system. We've been meeting with health plans to really learn more clearly about their products and how they will work with this population. So after that research, we really decided that the county organized health system would be the best model for implementation. And I'm going to affectionately call it as a COES moving forward. So it's a single plan, a public plan that's established but not operated by the County Board of Supervisors and governed by an independent commission. 2 or more contiguous counties, and those are counties that are side by side, may jointly form a single COES which serves the entire Medi-Cal population. Enrollment is mandatory for nearly all Medi-Cal beneficiaries. I believe some of the mental health services are still carved out because they're still in a Medi-Cal managed care for mental health. So what is a COES, or why a COES? It's the most effective managed care model for improving patient health outcomes. There's a strong primary care focus by establishing a patient-centered health home. Consumers and patients scored this model as high as with satisfaction at 90% compared to the 2-plan model or the geographic model or fee-for-service. It serves seniors and persons with disabilities effectively, and it's preferred by local stakeholders and providers. So why Partnership of Health Plan of California? While this was established by the governor in January, we've been meeting with them for almost 2 years and have established a relationship, we being SHARC. They are a nonprofit. They are committed to the Medi-Cal population. If you go on their website, that is their mission, to serve the Medi-Cal population. They have a demonstrated success using the COES model, significant experience in the 5 counties listed up above, actually 6, and most recently, Mendocino County, which is a rural community, they were expanded upon and started last July, and we've spoken to a number of our colleagues who are very satisfied with working with Partnership. And it wasn't smooth, but the thing about Partnership is they're very customer service friendly. So they really work to strategize and address issues. They're committed to working with Shasta County and other Northern California counties. There's about 8 of them right now. They have extensive record of serving seniors and persons with disabilities, and they have very low administrative costs. Their administrative costs are 3%. They invest back into the community and back into services. Some of the other plans start as 12% and above. Oh, I think I turned it The benefits of COES and Partnership Health Plan is we're going to have improved access and better health outcomes for our Medi-Cal beneficiary. It's more efficient use of taxpayer dollars because we will have improved access, we'll have better quality, and which will reduce, contribute to overall costs. Local governance and a sustained local voice in the delivery of health services. Partnership is committed to having a regional office, most likely in Reading, and that'll be 25 jobs up here to help work with the healthcare community. And accountability for measurable improvements, they actually pay for performance and do quality improvement and work with providers, so the rates are higher. I also would like to say with Partnership, they actually pay their specialists, for the ones that you have locally, a higher reimbursement rate compared to Medi-Cal, so that helps with access and getting specialists to see more of our patients. So we are asking on behalf of our collaborative for the board support of the COES model for Medi-Cal managed care for Shasta County and the expansion of Partnership Health Plan of California into Shasta County specifically. We believe that there will be a better system of care, building on a strong primary care foundation. It'll be the right plan with a local voice. Again, we will have seats on Partnership's board of directors. They've committed to that, so we'll again have that feedback loop. We'll have an accountability for measurable improvements, so we'll be looking at it systemically. And local healthcare provider stakeholders, we're ready to work on an effective transition. It's going to take a lot of work to get this to happen in June 2013, but we do have the commitment from our community to do that. So I thank you for your time and consideration of our request.
Thank you. Questions from the board? Supervisor Ball.
Thank you, Chair Modi, and thank you for the presentation. Very well done. Just a few questions. In your presentation, you mentioned some of the desired improvements, and you mentioned inappropriate use of the ER. And I understand what you're saying, but I think the average person hearing that probably doesn't understand what you mean by that. Could you
Sure.
elaborate a little bit, please?
I think folks who don't have access to a primary care physician and they just choose not to get preventative care, they don't have access to that. So when they do get sick and they're past that point, they go to the emergency room because they don't have any other way to go. So this would improve by having a plan really work with us in a business model. We'll have improved contracting. Each beneficiary will be able to choose their primary care physician, or they will be automatically assigned. So we'll be looking at improving the systematic access to that.
And it's such an important area, isn't it? Because at times our emergency rooms are tremendously overwhelmed and in an inappropriate way, and struggle to prioritize then the actual health care. You also mentioned health record exchange, and I hear this question frequently, and maybe you can elaborate on it. As we continue to expand our ability to exchange information, how are patient privacy rights advocated for?
They're advocated very strongly. In fact, it's very difficult to do health information exchange right now because that is taken into very seriously and in consideration. So we're actually across California, they're looking at systems, a way to maintain patients' privacy, but also give timely access to health information. So if someone does go to the emergency room and they've just had a test, the physician has access to that test and they don't have to order another one. So it's, we duplicate those types of, healthcare activities.
Perfect, thank you. How does our enrollment, our 1 in 4 enrollment compare to the rest of the state?
In the county or the open letter, I can say with the 28 counties, there's specific numbers, but I would actually defer to Marta because I think she's here because wasn't she here? Can you answer that, Marta? You better be here, Marta.
We're getting the yes, I can.
You're turning looking and she's ducking.
Well, you know it off the top of your head.
Good morning, Marta McKenzie, Health and Human Services. Yes, of course, Les, you may expect that we are disproportionately high in our Medi-Cal eligible population. Although in my career lifetime with the county, it's actually come down. We used to be about 60% of the births in Shasta County, maybe even 62% were Medi-Cal births. And now we're down about the low 50s. We have about 0.5% of the state's population, but 0.055% of the Medi-Cal population. So we are overrepresented in Medi-Cal recipients in Shasta, absolutely.
Thank you very much. I just wanted to draw that out because you have a tremendous burden that you're dealing with, and it's so important that we do it well. In the partnership health plan, you mentioned administrative costs of 3%, which sounds tremendously low to me as I hear that, as we hear all kinds of figures that are a lot higher in other avenues as well. But how are we accounting for the costs? And you talked about efficiencies and improvements in terms of what we're actually doing here. So can you deal with kind of the money part of it, how it's being paid for, and how is that utilizing, or how is it more efficient in terms of our overall costs?
Well, what I could say is the state will contract with partnership. They will develop a rate between two of them, and then they will subcontract with local providers. The good thing about partnership health plan, where compared to other health plans, is they see that there's needs beyond what's just provided in the medical or the doctor's office. So like they provide some access to transportation, because they see that as a need and a challenge for Medi-Cal recipients. Again, their whole mission is to serve the Medi-Cal population and provide a healthcare coverage. So they invest back into additional services and costs that help keep, we feel, this patient population healthier overall. For more specifics than that, Les, I would have to ask Jack Horn, the CEO, from that.
Well, let me just go to one more specific. You mentioned another 25 jobs approximately. Does that mean we're displacing some local jobs, or is this in addition to?
It would be addition to.
Okay. And I'll just ask one more question. You also stated that we're moving fast, and it sounds like you and this entire team have put a tremendous effort into it. In that fast-moving pace, are we ready for this?
Well, the governor has mandated it, so we have to get ready. So let's say that, one. Two, there's other communities and counties across the state that don't even know this is happening. So we've been lucky to keep our eye on the radar and we're doing the best we can to get ready for it and the best we can. Again, we like partnership because of their customer service commitment. In fact, every presentation that they do on the slide, they put, "We answer the phone," and they do. So the customer service and the commitment by them has been exemplary.
Well, I'll just end my time and defer to the rest of the board here. I just want to thank you. You have always shown leadership, not following, and I appreciate that.
Thank you.
Supervisor Kehoe.
Thank you, Chairman Modi. Ms. Bradshaw, thank you for your presentation today. I have 3 questions, and I'll be brief. Number one, is there any downside to Shasta County residents by embracing this new model?
Downside? At this time, I think what's going to be the challenge is implementation of it. I think we're going to have some bumps. I think nothing is perfect, and this is huge. And we haven't done managed care with this. The downside is, while partnerships pays a higher rate to specialists, we still don't have a lot of physicians and specialists, but it's going to help, I think, with the ones we do. So I think the improved reimbursement rates are going to be a benefit, but we still have to work on some access. I feel like having the partnership health plan here and the business model and having the system work closer together is going to be a benefit. I don't know if it's a downside. I think it's going to be improvement, but we have to do some education to get there continually.
Let's personalize this then. I have some friends that are Medi-Cal recipients, and they receive service from one of the local hospitals. How will their quality of care be increased by embracing this model?
Sure. If they're using the hospitals, I'm not sure they have access to a primary care, but they will have a choice of a primary care physician. And if they don't get that, they'll be automatically assigned. And that physician will also be an advocate in working with the hospitals to manage their care. If they do have a hospital stay, there'll be more coordination with discharge and making sure that they get the appropriate care in the right place.
My final question is this. I notice on your letterhead that Mr. Donnell Ewert and Ms. Marta McKenzie are joined with you and others in support of this, and they have no reservations. They're 100% behind this. Or should I ask that of Ms.
I think that would be, that's my understanding, but I think it'd be more appropriate.
She's coming forward. Ms. McKenzie, good morning.
Good morning again. Donnell's in Sacramento at a mental health fiscal training today, so he's not with us, but I can assure you that both of us are completely supportive. As you know, I've been on the County Medical Services Board for the last 6 years and learned a lot about healthcare delivery and what unmanaged care looks like. And for me, this is a tremendous opportunity to really advocate for coordination of care. Right now, Medi-Cal recipients have a hard time finding a primary care doctor in many cases, almost no luck in finding specialists, and a lot going to care at the emergency room, which I think is a problem for everyone because many of the medical conditions served in the emergency room are ear infections and other things that are appropriately not dealt with in the emergency room, but in a primary care office. So from my way of thinking, this is an opportunity for us to really manage patient care in a comprehensive way, avoid duplications of testing and services because you get it one day at one doctor and you might get it the next day in the emergency room, and it really is unnecessary expense and cost and really time. So for me, this is a wonderful opportunity to move towards a management system. My colleagues in Marin, Sonoma, Solano all sit on the partnership board and are very, very happy with their interaction and their ability to have a lot of local involvement in how partnership operates. And so I think for county government, it's a much better model than considering throwing ourselves to the wind of the competitive process and ending up with a insurance provider we've never met before, and that will serve the 27 or 28 counties with very little or no Shasta County involvement at all. So for me, this is a tremendous positive for our healthcare system.
Thank you, Ms. McKenzie.
Supervisor Hawes.
Before you leave, Marta, I just wanted to ask the question, will this help reduce insurance costs overall? It seems like it would because a lot is wasted in the emergency rooms. Believe me,
The
that's
management
very
of
expensive.
medical care absolutely is one of the harbingers, I think, of the future. There does need to be more control over the care that folks receive. It will be interesting over time to see how behavioral health services are integrated into a system, because we know full well that both substance abuse, mental health, and other services need to be integrated with someone's physical health care. Kaiser's a good model. Most people would say to you that they're very pleased with the care that they get. Family members I know are Kaiser recipients, and it's managed. You have care coordination as part of your physical health care and mental health care needs, so it's done in a comprehensive way.
It seems that it would be way more efficient than the way we've been doing it. So
It absolutely is.
I'm pretty happy about this.
Well, I have just a couple of questions. Perhaps I'm a little confused. We talked about sort of supporting this, but at the same time, you're telling me that the governor has mandated it, so I'm not quite sure where the choice is.
The choice is the model of managed care. So geographic, remember on the map, there was like 4, actually we're in fee-for-service now. There's geographic, there's the 2-plan model, which we're not really eligible. We don't have the lives to have a local initiative and a commercial product, and then the COES model. So what we're asking for is your support for us to say to the state, and we're doing this in all the other 7 surrounding counties as well. Folks are at the Board of Supervisors asking that as well, to say, you know, we support the COES model and we believe that that's the most efficient model for our communities.
Great, thank you for explaining that.
Sure.
A couple of questions I think already got asked. One was how easy or difficult it would be to create this, and you've already talked about that. The timing, you also mentioned that we're on a mission. So and we just talked about the cost and the service. So the last question I think I would have is the funding is coming from, the funding for this?
It's the Medi-Cal funding, yes, it comes from the Department of Healthcare Services. It's reorganizing how Medi-Cal is paid.
And hopefully doing it more efficiently.
Yes.
Cost effective.
Yes.
Great, thank you. Mr. Kehoe.
Thank you, Chairman Modi. Then following this enlightened presentation and the board discussion, I'll move approval of the resolution as read this morning before the audience and before the board.
Second. Moved in second. Any other discussion? Seeing none, all in favor, please say aye. Aye. Opposed? Motion carries. Thank you very much for the presentation.
Thank you very
And
much.
thank you all for coming and supporting this.
Thank you.